Good morning to everybody. It's a pleasure for me to be here this morning, and together we'll have these 20 minutes regarding the cardiac guidelines that we published in our society. The detection of congenital heart disease is an important issue, socially speaking, because heart defects are very frequent in the newborns, because they account for more than 40% mortality up to 1 year of age, because we miss them all the time at the second trimester anomaly scan, and this is the crucial point. We should try to strain and challenge our capacities for screening and for picking them up. And finally, because there has been some evidence that at least for some of the congenital heart diseases, prenatal diagnosis may contribute to improved survival rates. These are actually the lesions for which there have been some publication in the past, especially transposition of the great arteries, which has an excellent prognosis once the bottleneck of the perinatal period has been overcome, thanks to prenatal diagnosis. But we should be aware of these results because all of them are reporting short-term outcome and not long-term outcome. And it seems that if you compare, there have been some more recent papers, long-term outcome for the cases in which there was prenatal diagnosis and those in which there wasn't, this difference is no longer there. But anyway, in the doubt, it is our must to go and try to detect this type of congenital heart disease as early as possible in pregnancy. You see here from this table two issues. The first one is that no matter what type of screening views you're using, the detection rates that you get in the screening setting is much lower than you should get if an expert would use the same approach and the same screening views. And this is because, of course, of several reasons that I will show in the next slide. And the second issue is that there is a significant difference if you're using the four-chamber view only and if you're using the four-chamber view topped up with the assessment of the great vessels. And you see here that the detection rate do improve despite the fact that if you use the outward tracts evaluation as well, you should get a 60, at least to 80% detection rate. These are the factors that may affect and may be responsible for the lower detection rate. The examining of the experience, maternal obesity is indeed a social problem everywhere in the world, also in developing countries. Fetal variables, scanner variables, transducer frequency, and so on and so forth. Please refer to the wonderful presentation by Rabbi on the website regarding setup that we had last year here, if you have any doubts. And of course, the time of examination, you have a complete session dedicated to the early fetal echo in the early afternoon, and so take care of that. As for the screening tools that we have actually the increased nuchal with normal karyotype, and we have the classic second trimester cardiac screening tools. As far as the nuchal, and after the usual enthusiasm for whatever discovery you have in science, then the actual potential of that tool, of that screening tool, is much more than what after the initial discovery is becoming. You may think, and this is a huge series, you see a multicenter series, that no matter what is the lesion, but roughly 20 to 30% of all types of congenital heart disease with normal karyotypes will have indeed an increased nuchal in the first trimester. So the potential detection rate, if you use the nuchal as a screening tool for cardiac defects, may be just in the range of 20 to 40% if you are very optimistic. So that's not an issue. It may help in drawing the attention to the study of the fetal heart as early as possible, but we are left with the cardiac screening examination in the second trimester. And we are coming to our guidelines. You see here that you can use the basic cardiac examination, which means that you're using the four-chamber view only, or the extended basic cardiac examination, in which the four-chamber view is coupled with the assessment of the two outflow tracts. And that is making the difference in the detection rate, actually. This is the publication that you can pull down from our website. It's also in your CDs and in the White Journal, of course. And this is the media, the multimedia that was developed by Greg DeVore with our task force some years ago to support the understanding and the approach to cardiac screening in the fetus. The most crucial thing is to assess in a correct way both the four-chamber view and the outflow tract. And so we'll go very briefly over these three actually views to see how to perform this with the help, partly with the help of this audiovisual. You see here, first of all, you should assess the heart, the size of the heart, the cardiac axis, and you get the cardiac axis by drawing a line along the interventricular septum, which gives you the actual orientation of the heart. And then you get the midline, mid-sagittal one, and then you measure, you have also a software on your computer. You can use your scanner facilities to measure this angle, which should be 45 degrees plus or minus 20 degrees. And then by looking at the four-chamber view, you should try to tag the four-chamber view, and you use usually a posterior-anterior orientation, in which the chamber which is closer to the descending aorta is, most of the cases, the left atrium, and the ventricle just below the sternum is the right ventricle, and then you tag and assign the other chambers. And then you can detect and pick up all the other anatomic details, the flap of the foramen ovale, which in this clip is a bit redundant, you see here, but it's quite normal, no worry about that. This is the important structure of the septum primum, which is absent in all types of atrioventricular septal defect. You should bear in mind to check for this part of interatrial septation. And then you have the offset appearance of the two AV valves, two chambers, and you see here that the right side is rounder than the left side because it has the moderator band on the top of it, and the apex is made by the left ventricle. And then you should check for the thicknesses of the free walls of the myocardium and interventricular septum. And these are all the structures that you may detect on the actual four-chamber view of the fetal heart. And the same approach you should get on the left outflow tract that you see here. You see the left ventricle. This is a rotational approach. I will show in the next slide or the next slide what this does mean. You have the outflow tract, the septum, the aortic valve here, and the whole of the left outflow tract views here. And then you should be aware that you can make out also the remaining anatomic details. This is the left atrium with the mitral valve, and you see the mitral aortic continuity, which is there in all normal cases. And in front you have part of the right ventricle that is always there. And the same thing you can do on the right side, on the top, just a few degrees up, if you use the sweep with this lateral approach, and you see the infunibular portion of the right ventricle. Then you get the main pulmonary artery and the bifurcation with the left and right pulmonary arteries. Bear in mind that if you get the short axis with the nice snake, or how you call it, image with the short axis, one of the two branches is not a pulmonary artery, is actually the ductus going behind. So don't take it for the bifurcation to the two pulmonary artery actually. Whenever you assess the fetal heart, this was a transverse four-chamber view, whenever you assess the fetal heart, you should always try to get both approaches to the four-chamber view, both the transverse and the apical four-chamber view, because the definition of the structure that you're looking at is strictly dependent upon the angle of insonation. So with the lateral approach, you should actually be able to assess the thicknesses of the myocardium and the chordae tendineae, whereas with an apical approach, you should try to get this very nice view of the offset appearance of the two AV valves and have an overall idea of what is the aspect of the fetal heart. So do not take it for assess a four-chamber view unless you've gone both through the transverse four-chamber view and the apical four-chamber view. If you're able to tick all the issues, all the items that are on this list, you can actually, just by looking at the four-chamber view, can detect very abnormal hearts, such as absence of the cracks, consistent with the atrioventricular septal defect, or hypoplasia of one chamber, in this case was the left, but in another case was the right ventricle, or displacement of the attachment of one of the valves, namely the tricuspid in case of Epstein abnormalities, and also some more subtle abnormalities such as moderate prevalence of the right ventricle with the ventricular disproportion, or late onset disease such as tumors or the cardiomyopathies. But also because critical obstruction of the outflow tracts will determine a profound modification of the four-chamber view. Just by looking at the four-chamber view, you may also reach the diagnosis of abnormalities that are actually located outside the four-chamber view. In fact, in case of pulmonary atresia with intact ventricular septum, in most of the cases you will have either a very large heart, such as this one, if the tricuspid valve is insufficient, or an hypoplastic right heart if the tricuspid valve is sealed or highly stenotic. And the same applies to the left heart. In case of critical aortic stenosis, Rabe will show this to you later, you have very abnormal four-chamber view as well. So if you look in detail the four-chamber view, this gives you the possibility to detect all abnormalities that actually are located at atrioventricular junction, but also to suspect some abnormalities that are located outside the four-chamber view. Then we move to the outflow tract evaluation, and we start, of course, with the left outflow tract, because from the diaphragm towards the upper mediastinum, you get the four-chamber view, left outflow tract, right outflow tract, and traversal view. And so we use this type of approach, and this is the classic sweep approach. But you should bear in mind that you may approach the assessment of the left outflow tract in two ways. One is the so-called sweep technique, in which you just sweep your transducer, and I'll show you the actual movement of your hand on the abdomen. In this way, from the four-chamber view towards the outflow tract without angling the transducer. And the other one is the rotational technique, in which you rotate your transducer to open up the aorta. And this is what I mean by that. If the fetus, here are the feet of the lady. If the fetus is in the vertex presentation and use the sweep approach, you actually just make 3 steps, 1, 2, and 3. And then you have four-chamber view, 5-chamber view, or left outflow tract, and right outflow tract. Compared to this one, in which you, from the four-chamber view, you just tilt a bit the transducer, okay? So you open up the aorta, because the aorta is oblique towards the right shoulder, like this. And then you angle the transducer to get the right outflow tract. Of course, in this clip, the movements are magnified, because for you to understand the actual movement, but of course, this will be a few degrees of rotation and tilting of the transducer. Okay? What is the difference in what you see on the screen? Since the aorta is oblique like that, and you cut it cross-sectionally, virtually cross-sectional, salami-like, if you're using the sweep, the amount of aorta that you are actually displaying on the screen is smaller. So it's a bit more challenging for you to assess the septo-aortic continuity, not as much as in the lateral approach, but especially, as I will show you later, in the apical approach. So this is with the transverse approach, the sweep, and this is the rotational, in which by just angling the transducer, you open up, you align it with the ascending aorta, and so you, at the end of the day, will have a longer tract of the aorta to give you more confidence in assessing the septo-aortic continuity and ruling out abnormalities at this level. And the problem is much more challenging if you're using an apical approach. This is not a wonderful volume. This is a volume taken from an everyday patient in everyday life. And you see here, if I'm using the sweep, the actual orientation of the septum and the ascending aorta is a bit blurred, and you're not quite sure, and you get anxious if there is not any malalignment here or any defect or whatever. If I'm using the rotational technique, also with an apical approach, I can actually make out very nicely the whole of the septo-aortic continuity. So keep this in mind. I'm not recommending to go always for the rotational, because it's a bit more challenging manually to get it. But you should master both approaches to make a good cardiac screening. And if you use this approach, no matter if you're using the sweep or the rotational, then again you may end up by diagnosing the most common abnormalities of the left outflow tract that are valve abnormalities. You see here the normal aortic valve disappears completely from the lumen during systole, because the cusp will flatten along the walls of the aorta. If there is a dysplasia of the valve consistent with the moderate stenosis, you see there is no ventricular overload here. the cusps are thickened and will persist in the lumen across the cardiac cycle. This is minor lesion anyway. The most important one is the conotruncal group, and this is the classic malalignment VSD, in which the septum is posteriorly deviated, and so the tip of the septum is not looking towards the anterior wall of the aorta, but is looking in the middle of the aorta, so the aorta overrides the defect, and Julien will show you the differential diagnosis regarding this group of abnormalities. And then you have the possibility to have two parallel vessels with absence of the crossover of the two arteries. And then if both vessels are mainly connected to the anterior ventricle, it will be a double atrial ventricle. If, on the other hand, each vessel arises from a different ventricle, you will have classic transposition of the great arteries. And more or less the same things you can detect if you're using the right outflow tract. Here you see that the right outflow tract with the long axis of the right ventricle is very, very close to the three-vessel view, because the pulmonary artery is on the top of the mediastinum. And by using this type of approach, you can actually differentiate between a normal outflow tract and a dysplastic valve consistent with a moderately severe pulmonary stenosis. Or, in some other cases, you see here, this lesion may evolve towards a functional pulmonary atresia in which the cusps are not opening anymore because of the pressure, and then the valve seals actually, and then you have a late onset pulmonary atresia with detected ventricular septum. But in this case, the size of the pulmonary trunk is good, so prognostically speaking, is not that important. But on the other hand, some cases you will have a pulmonary atresia from the onset of the lesion, and so in this case, the pulmonary trunk and branches will be severely hypoplastic. This is the illustration of the screening procedure, and you see that in a closed area where all the patients are referred to the same hospital, which is Trondheim Solheim Group in Norway, you see that this makes a difference, and these were statistically significant differences in the detection rate at screening and cardiac screening. Now, once these babies with the suspect of congenital heart disease have been picked up at screening, at mid-trimester screening, they are referred for expert assessment to referral centers and experts. So we sat down at table and tried to decide and to agree among ourselves on what makes a fetal echo and how this should be performed. And we came out with a list of things, anatomic details, to be checked mandatory during fetal echo in referral center, and with a list of mandatory or optional technique that should be used to assess what. And you see here the list, and you see here the technique, and if they are believed to be mandatory, optional, or highly desirable, depending on the type of abnormality. And you can also download this from our website. Now, in the title of my presentation, and this is actually a multi-slides just to show you the sequential anatomy of the fetal heart, on grayscale to check the anatomy, and on color Doppler to check the functional status of the atrioventricular arterial connection at the same time. So if you see the title of my presentation, there was a beyond cardiac guidelines and fetal echo. So what is beyond? Probably beyond is just what make a fetal cardiologist an expert fetal cardiologist. And what you need is for sure an expert that you see here, a good guy or girl. Then you need, of course, because if you have to assess difficult cases, you need a very good machine. And what makes the difference probably is that not only the machine and the guy, but what's inside the guy, because you need a nice brain to try to make the difference and to reach the final diagnosis. For example, you need also a boot full of books regarding pediatric cardiology if you are coming from an obstetric background, or regarding malformation, extracardiac malformation, and OB if you're coming from a pediatric background, and genetics as well. And this will lead you to make some Pavlov reflex. And so if you have an IVSD and suspect Down syndrome, and you have read a nice paper by Rabbi Shawi in 2005, you go and check for the aberrant right cyclic artery that you see here. or if you suspect right atrial isomerism, in this case you go on the trivessel view and check for the presence of abnormal pulmonary venous return, or if you suspect medullary lesion and you have a final talk by Rabbi this afternoon regarding this issue, you go and check for the right aortic arch of the presence or absence of the thymus. And the final issue will regard the timing of the examination, because we do know that natural history of disease is there, and especially for the fetal heart, it's completely different what you can get in diagnostic term if you're running an early fetal echo, in which the major difficulty will be to assess the ventricular arterial connection rather than the four-chamber view. At 20 weeks gestation, you will detect most of the lesions, so it's the most important and most sensitive time for screening, 20 to 24, 25 weeks, if there is no termination, no limit for termination of pregnancy in our country. And later on, you will pick up only the cases which you missed, and the second trimester anomaly scan, or the late onset ones, such as some cases of coarctation, tumors, cardiomyopathies, and some cases of semilunar valve stenosis. So try to keep this in mind, because of course otherwise you will have a lot of false negative results. So to conclude with what is the diagnostic flowchart for fetal CHD, once you raise the suspect at the 20-week anomaly scan, refer the patient for expert assessment, and the fetal echo is performed. And within the referral center, all additional procedures that should be performed are done. So if there is a need for karyotyping, this is done. Fish analysis for microdeletion or other abnormalities such as the charge that Rabbi picked up yesterday. Recheck the extracardiac anatomy, because some tiny details, some subtle details may orientate towards any given syndromic condition, which has a cardiac and extracardiac involvement. And then if there is an isolated cardiac lesion, or also if it's not isolated, but then one of the tasks is to differentiate between ductus-dependent and non-ductus-dependent lesions at the time of diagnosis. For the patients who elect to continue the pregnancy, they are reassessed, usually monthly or at 3 weeks' time, according to the setup and schedule of the referral center. And before delivery, before recommendation of delivery, should reassess again this, because some lesions that were not ductus-dependent at diagnosis at 20 weeks of gestation will become ductus-dependent later on in gestation. And so recommend also local hospital delivery in this case, whereas mandatory all cases of neonatal emergencies should be transferred in utero to tertiary referral center, which is not only an hospital where there is an expert in fetal echo, but there should be a multidisciplinary keep. The delivery can be spontaneous, should be spontaneous, should be no problem with delivering also the most terrific, the most poor prognosis cases spontaneously. There should be a neonatal intensive care unit, because IUGR is indeed a problem. Also, both because there are some cases which are syndromic, and because in some lesions there is an association with increased rate of growth retardation. Of course, there should be pediatric cardiology for catheter intervention and cardiac surgery facilities. And last but not least important, because some of these cases will have gastrointestinal abnormalities or renal abnormalities to be dealt with before the cardiac lesion itself, you should have a good pediatric surgery facilities for dealing with associated extracardiac anomalies. And thank you for your attention.